Hello and welcome to the Independent Health and Aged Care Pricing Authority's online stakeholder forum, where we're introducing our consultation paper on bundling arrangements for general use items on the prosthesis list. My name is Joanne Fitzgerald. I'm currently acting CEO of the Independent Health and Aged Care Pricing Authority, or IHACPA as our abbreviation is. And I would like to start by acknowledging the traditional owners of the lands on which we're meeting today. For me in Sydney, that's the Gadigal people of the Eora Nation, and I recognise their continuing connection to land, water and culture. I pay my respect to elders today and those who walk in spirit. In today's session, we will be taking you through our consultation paper on the bundling arrangements for the general use items, and we're providing you with an opportunity to engage with and ask questions ahead of the advice that we are required to provide on this. So I'll be participating in the question and answer session along with two of my colleagues. That is Kees van Gool, who is Executive Director of Pricing and Analytics at IHACPA, and Trent Yeend, who is IHACPA's Senior Data Scientist. So Kees and Trent will be joining me as Q&A panelists. But first, Trent's going to provide us with an overview of the consultation paper as an introduction to the session. So before I hand over to Trent, just a reminder, obviously this is a Q&A. There is a Q&A widget in your browser window where you can post questions to the panel. And you can also, once those questions are posed, you can use the thumbs up button to vote up those questions if they are a question that you would also like to see answered. So we look forward to that Q&A session. But before that, I will hand over to Trent to take us through the consultation paper.
The consultation paper that we released last Wednesday on bundling arrangements for general use items on the prostheses list. We'll start with the background on prostheses list reform and IHACPA's role in providing advice and the timeframes around the advice that we'll be providing, as well as the consultation process that we're currently undertaken. And then we're going to look at the consultation paper itself, which has three sections, the first being on data sources, the second being on classification systems, and the third on other considerations of relevance to the utilisation of general use items on the prostheses list. So to begin with background, obviously, as you know, the prostheses list is a schedule of medical devices and benefits that define the minimum amount that insurers are required to pay hospitals that utilise these devices for privately insured patients. And these devices cover devices that are surgically implanted or essential to the implanting of such a device or critical to the ongoing function of such a device. The prostheses list reforms that we're talking about commenced in 2021 and were announced in the May 2021 federal budget and were intended to be implemented over a 4-year period. They're aimed at, broadly speaking, improving the alignment of the prostheses list, a schedule paid in the public hospital system, streamlining the administration of the prostheses list, and also better defining its purpose and its scope. So the Australian Government Department of Health and Aged Care has requested that IHACPA provide advice to support the implementation of prostheses list reforms. And to that end, in March this year, IHACPA established a public benchmark price for prostheses in Australian hospitals. And this benchmark price has informed reductions in prostheses list schedule benefits that were implemented from July this year and are intended to continue to be progressively implemented over the coming 4 years. As for general use items, the reforms aimed at clarifying the scope of the prostheses list include the removal of items identified as ineligible, and general use items identified for removal from the prostheses list include select infusion pumps, gastronomy tubes, powders, sponges, staples and tackers, liquid sealants, arterial closure devices, and so forth. There's a list of almost 500 billing codes that are identified for removal from the prostheses list, and this set of under 500 billing codes is identified by Part D of the August 2022 publication of the prostheses list. Now, for the actual IHACPA advice itself, the department has requested that IHACPA provide advice on bundling arrangements for general use items. The purpose of the advice is to support the private sector in establishing alternative arrangements for the payment of payment of benefits for these items once they're removed from the prostheses list from 1st of July next year. And IHACPA's advice will relate to the two items used in admitted services provided to privately insured individuals in private hospitals, public hospitals, and day facilities. The timeline for IHACPA's advice, we're expecting to provide advice to the department on alternative bundling arrangements in December this year, so in a couple of months. And if required, IHACPA will provide the department with supplementary information in April 2023, so next year, to assist with the interpretation and use of its advice that we provide in December. We have established a Prostheses List reform working group, and the purpose of that working group is to support the development and provision of advice that is evidence-based and fit for purpose, and the membership of that group is on screen now. We also have a public consultation process that that's currently active. It commenced last Wednesday on the 14th of September. We released a consultation paper on bundling arrangements for general use items on the Prostheses List, is its title. Submissions close 4 weeks later at 5 p.m. on 12 October. And feedback to this consultation will inform the development of IHACPA's advice. IHACPA is holding 2 online stakeholder forums, which include live Q&A sessions, the first of which we're here right now doing, 21st of September. And the purpose of today's session is to introduce the consultation paper and also to facilitate discussion on IHACPA's role in providing advice and the public consultation process. We are holding a second stakeholder forum in mid-December, and that shortly after the provision of our advice to the department, and that stakeholder forum will be presenting our advice and also facilitating discussion on its interpretation and use. So now to the consultation paper itself. As I said, there are 3 sections that the consultation paper focuses on. Firstly, data sources, classification systems, and thirdly, other issues and considerations. Submissions, as for submissions for the consultation paper, stakeholders are encouraged to provide empirical information such as observational data or analysis to support their submissions. IHACPA will ensure the confidentiality of any such information in cases where this is required. All submissions will be published on IHACPA's website unless respondents specifically identify any sections that they believe should be kept confidential for commercial or other reasons. And also a summary of the consultation feedback will be published in mid-December. So on to the actual consultation paper sections, the first section being data sources. IHACPA is intending to make use of a range of data sources to ensure the advice is evidence-based. The data sources we're considering for use include the Prostheses List itself, which, as I mentioned before, is used to identify these general use items as billing codes. Secondly, the HCP data collection, the hospital case mix protocol data collection, will be the main data collection that we're intending to use to understand the actual profile of utilization of general use items across the sector. And that data collection, for those of you that don't know, contains detailed billing code level device utilization information across the sector by hospital, as well as episode of care information, as well as linking of those device utilizations to the episodes of care in which they're used. We'll also be using the PHDB data collection, which provides us with a population of admitted episodes of care across private hospitals nationally. And secondly, IHACPA has a national public hospital activity data collection that we use for our national efficient price determination and is used for activity-based funding more generally. And that will be used to understand the population of privately insured admitted episodes of care within public hospitals. And so those 2 data sources together will be used to have a view of the population of admitted episodes of care provided of privately insured individuals, and we'll be using that to understand the representation of the HCP data in that regard. And lastly, we'll be using APRA statistics to understand the population level statistics on device utilization and benefits paid. And although these statistics don't specifically identify the general use items that we're talking about here, they do classify item utilization and benefits paid by category and hospital type. And so we're looking to understand the representation of the HCP data at that level that it provides. And so we've got consultation questions here on the screen, and they basically canvass the appropriate use of these different data collections for the intended purpose, and in particular ask for responses with regard to strengths and limitations in this regard, and also if there are any other additional data sources that IHACPA should be considering for use in the development of advice. So the second section of the consultation is on classification systems. IHACPA is considering the use of particular classification systems for the purpose of creating clearly defined bundles to capture different usage and paid across the sector. So there are three main areas of classification that we're interested in. First, the actual classification of the products themselves, and we're intending to use the Prostheses List product classification of categories and subcategories, groups and subgroups for that purpose, to some extent at least. And then secondly, we're looking to characterize and classify the actual services in which these items are used, and we're intending to use the ICD-10-AM disease classification and the ACHI intervention classification for this purpose to profile and classify the actual episodes of care in which these devices are used. And finally, we're looking at hospital characteristics and determining the extent to which we should be incorporating classifications such as public-private day facility or potentially other hospital type classifications to further define the bundles. And again, the consultation questions are on your screen, and they canvass the appropriate use of these different classifications for this purpose, and also ask if there are any other classifications that should be considered in the development of advice. Finally, we have the final section, which is on other issues and considerations. Now, IHACPA understands there may be contextual factors regarding the purchase and utilization of general use items that are relevant to the formulation of advice. We're seeking input on issues of relevance, including the impact of COVID-19. Now, clearly there are short-term and long-term impacts of COVID-19 on service provided in the private health sector, and we're seeking to understand the extent to which these impacts may be relevant to the formulation of these general use item bundles and the associated pricing of them. And secondly, whether there are existing arrangements between hospitals and insurers that may be of relevance in the formulation of advice. And this is particularly with regard to the fact that the advice is intended to support insurers and hospitals in formulating alternative arrangements. And so these alternative arrangements need to be incorporated and integrated into the existing arrangements. And IHACPA is seeking to understand if there are specific aspects of the existing arrangements that bear relevance to in this regard, whether they're technical specifications of the arrangements or whatever it might be. We just want to have an understanding of existing arrangements and how they might influence the formulation of our advice. And finally, we're looking at the attribution of general use items to episodes of care. As I said before, we've got devices linked to episodes, and there potentially are instances of general use items that might be multi-use or multi-pack items and may have and maybe sort of billed against one episode of care and used against multiple potentially, and we want to understand the extent to which that is the case. And we're also asking if there are any other issues of relevance to the formulation of our advice. And so that covers the consultation questions there on the right-hand side of the page as well. And so that covers the consultation paper. And next we're on to our live Q&A session. And I think our panelists are back with us.
Thank you, Trent. So yes, we are moving to the Q&A portion of the session now. And I would like to introduce James Chen, who is going to be our moderator for today. James is IHACPA's Acting Director of Aged Care Costing, and he is going to be moderating and feeding us the questions. So I'm not sure if we've got any questions yet, James. Please don't be shy in coming forward. I know who wants to be first.
Yeah, thanks, Joanne. So hi, everyone. Welcome today to today's Q&A session, where the panel will be responding to your questions on our public consultation process and the role of IHACPA in providing advice on bundling arrangements for general use items. So we've got a good amount. We've got about 40 minutes to take your questions, and which I encourage you to post via the Q&A widget on your browser window. So you can also upvote audience questions that are of interest to you. So let's start. We've got one question. So let's start with our first question. So has there been any IHACPA data collection for day hospitals?
So my understanding is that the HCP data collection covers privately insured services, episodes of care in private hospitals, public hospitals, and day hospitals. And the extent to which that may not provide complete coverage, is part of the process of addressing, as I mentioned in one of the sections, the data section. We're looking at understanding the representation of the HCP data across the sector, and so we will look to understand the activity undertaken in day hospitals and the extent to which it may or may not be represented in the HCP data. So we will certainly be looking at that, but also if there are specific aspects of representation for particular components of the sector, then we would want you to bring that to our attention through the consultation process.
Great. Thanks, Trent. We've got another question that's just come through as well. So how does IHACPA propose to allow for different funding models? How will bundles work in per diem funding, and will NPBC theatre banding be considered?
I listed the main classifications that we were intending to use for the purpose of defining the bundles, but there are other classifications that may be relevant, such as the theatre banding, which we indicated in the actual consultation paper. So basically, we're open to the use of other classifications, not just, this is about the actual defining the bundles themselves, and so we may consider the use of further classifications if the ACHI and ICD classifications and etc. don't in their own right satisfy the actual objectives. As for how the bundling advice, what was the question? So how will it cater for different funding models, such as per diem funding models? Our intention is to provide a bundle. The definition of bundles will be episode level bundling, so it won't be related to day, like length of stay. So it would be a single payment for each bundle. There would be a single payment per episode of care of that bundle type. That's how we intend to provide structure, frame the actual bundles.
All right, thanks, Trent. We've got another question about public hospitals. So HCP for public hospitals, are there any plans to improve compliance, quality, or consistency of reporting?
Perhaps I can take that one, James. I'm happy to take that one. So certainly, as Trent mentioned, part of the purpose of this consultation is to understand gaps and current issues with the HCP data. We are aware of already gaps and some current issues. The HCP data is obviously managed by the Department of Health, and so it is ongoing work with the department to make sure the HCP does provide us the data we need, but also for all of the other sources that HCP data is used for as well. HCP data is not just needed for us for the prosthesis work. We also use it in the developing the NEP model in some circumstances, and when we're looking at pricing adjustments for privately insured patients in public hospitals as well. So it is definitely something that is in discussion with the department as the data managers of that. And also a big consideration too of how sort of forward with these items being removed from the prosthesis list. We do recognise that we have good data at the moment, but once they're removed from the prosthesis list, that may be an issue as well. So that data collection is still for open discussion.
All right, thanks, Jo. We've got another question here. So most health insurers hospital agreements are per diem or episodic. Will the analysis or utilization be performed by MBS or DRG? So this isn't contained in the HCP data. So throw that to the panel.
So the HCP data contains the ICD and ACHI classification information, as well as it also contains MBS item detail per episode. And so we are able to utilize, if required, we can leverage the MBS item component of the HCP data to further provide definition to and characterization of the bundles. I'm not sure if we regard that as being required at this point. Certainly it's open for feedback from stakeholders through this process, and yeah, so we'll be looking, we'll be investigating that and confirming if it's required. And so the second part of the question, was there a second part? Sorry.
So the question was around, sorry. I think you've answered that, Trent. So we've got another question that's come through. So there are procedures in endoscopy specialty where the use of hemostatic clips will be unknown until the endoscopy is performed and the number of removed polyps that require a clip. So it could be none, 1, 2, 3. How could this be bundled appropriately?
So we're, I guess we're bound by the data, the information that's captured and the classification of the services provided and the clinical characteristics. I think the whole purpose to this bundling approach is to try and frame a profile of the utilization of these devices or items at an episode level across the sector, and establishing a single price. It's obviously going to be different to device, sort of the current system, which is device level payment, a device level payment mechanism. So there'll be an extent to which it's not going to be capture every single aspect of variation in device utilization at an episode level, and we're just going to have to do our best to understand and provide sufficient information for the sector to understand the variation in utilization for each of the bundles.
All right, thanks, Trent. Is it expected that the bundles will remain static, so at the current 492 items? And how will new products that meet the general miscellaneous definition be included?
Okay, so I'm not sure if it'll be, well, sorry, maybe I'll put it a different way. Our intention is to try and provide sufficient detail on the actual bundling definition in terms of its classification and utilization rates and associated benefit levels, so that it may be adapted over time, so that it may change over time as utilization rates change or benefit levels change. And we also intend to, in sort of defining these bundles, we're not going to necessarily be defining them at a billing code level and say, this bundle has so many rate of this specific billing code. We're going to be looking at higher levels, and so that's why we're talking about different categories and subcategories and so forth in the prostheses list, product levels of product classification, and each one of those levels of the product classification will have a utilization rate associated with it, or a range of a spectrum of utilization rates associated with it, and an associated average average benefit paid associated with it. And so it'll be, I guess, we'll just have to frame those specifications in such a way that those different parameters can be varied over time to deal with changes in the mix and changes in benefits and changes in utilization.
All right, thanks, Trent. We've got another question about the data sets. So I understand that many of the data sets mentioned don't provide full coverage of item use. Will this affect the bundling method, or will you be able to account for it?
So if it doesn't capture, so the expectation would be that the HCP data does capture device, does adequately capture device utilization. But if there is an extent to which general use items, for example, are used in services provided to privately insured patients, and those general use items are not recorded in the HCP data, and potentially not charges aren't raised by billing code type thing. If they're somehow funded through more other components of arrangements between hospitals, then that's obviously a data representation issue that we would seek to understand the extent or the materiality of. I'm not sure we have anything at hand to quantify the extent to which general use items are not captured in the HCP data, but we would seek to understand that from stakeholders. And that's where I think data is really important in this. If this information is not being captured in the HCP data, then we need to understand and quantify the extent to which it is not. We need to get beyond the anecdotal to the quantifying these sort of effects.
All right, thank you. We've got another question around the items being removed from the list. So why is it necessary to remove these items from the list rather than creating a new item for each bundle within the list?
Let me try that one, Trent, to give you a bit of a break. So this is where, as acting CEO, I'm going to come back to a bit of a scope comment, and it is part of the broader prosthesis list reforms that the department are undertaking. And my understanding is that these are items that they've reconsidered, that they probably don't meet the definition for the prosthesis list, and it is sort of policy reform that the department have undertaken, and IHACPA's role in that is providing advice to the sector on determining those bundles. So it has been a sort of a decision of the department in order to do that.
All right, thanks, Joe. We've just got another question about the difference between private and public hospitals within regards to the prosthesis list. So will there be consideration of the disparity between public and private hospital payment arrangements? So for example, insurers who only pay at shared room rates regardless of actual utilization, or is this something you were looking for as part of the consultation?
I think that maybe those sort of potential issues, the extent to which they may occur or the differences that may exist, is why we're considering the use of hospital type as part of the definition of these bundles. Like, if there are fundamental differences between hospitals of different types that are legitimate and not and specifically relate to differences in the actual utilization characteristics of these items, then defining the different bundles by different hospital type may be regarded as appropriate. And so that's how I think we would at least start to address that issue.
All right, thank you. So we've got another question. Will bundling to occur for contracted hospitals as well as non-contracted on second tier default benefits?
So I think that as it currently stands, the prostheses list as a payment mechanism is a separate. It supports the payment of benefits from insurers to hospitals. Once they're removed from the list, they need to be I guess these arrangements need to be incorporated with other existing arrangements that aren't the prostheses list. Whether they're integrated into the arrangements that are referred to here is a question that remains open, but in the first part, we'll be providing advice so that arrangements could be established for the payment for these items in their own right and in isolation, and then it may be a matter of how this sort of bundling payment mechanism might be integrated into other mechanisms. That's a secondary question, I think.
All right, we've got a few questions about the future of the Prostheses List. Is this a one-off, or is it envisioned that the process will be undertaken again in the future?
So, hey, Keys, how about you? Do you want to have a go? Because I feel like,
So I think, sure. Take a sip of water, Trent. So I think the work that we're currently doing is one-off, as in that's the request that we've received to do. However, I think we're aware that obviously there may be changes required or future technologies that might be of consideration. So we have to think about how the advice might need to change if there was such a system. So we do have, whilst we are focused on that first set of initial piece of work around the general use items that are coming off the list, I think we have an awareness that something might need to keep going and need to be revised and updated. So that advice might come into what Joe was mentioning before around what sort of data do we need to ensure that could go on into the future.
All right, thanks, Keys. So will you be looking at bundling all the items, so the roughly 500 that will be removed in the Prostheses List? Are there items that shouldn't be funded or covered under a theatre band payment?
So it's I'm not sure the answer to the second part, but for the particular items and the payment, creating a bundling for these specific items, of which there's a little under 500 of them currently on the Prostheses List. Our intention is to provide a set of defined bundles and for that complete list of items, so to be comprehensive in the advice with regard to that list of items as identified on the August 2022 Prostheses List, Part D.
All right, thanks, Trent. So we've got another question here. So will you be providing advice to the department on the implementation of the bundles rather than how to calculate or compose the bundles, particularly on making the bundles mandatory?
I can answer that one. So it probably is a bit too early for us to say that. It sort of depends what comes through its consultation. Obviously, we have been engaged to do this technical piece of work, but I'm sure the department would be open to further insights from us on that. So, in terms of, our ability to sort of specify things as mandatory, or in fact the department's ability to specify things as mandatory, I couldn't really say that. Like, it's advice that we're providing at the moment, and so it would be advisory in its nature rather than any ability for us to mandate that, and then the department can take on board that advice should they wish to.
All right. Thanks, Joe. Another question's come through. So some of the general miscellaneous items are linked to high cost consumables with the costs absorbed by private hospitals. Are you familiar with these costs on the procedure level? And is this being taken into consideration as part of the bundling model? So one of the examples is sleeve gastrectomy procedures.
So I'm not, maybe that is I'm not sure, but maybe that's referring to where the prostheses, so potentially the item is used and a charge is raised against a billing code, potentially, I'm not sure, and then the Prostheses List minimum benefit is used and a benefit is paid, but maybe that benefit only partly covers the device, and the extra costs associated with that device are covered through other components of arrangements between insurers and hospitals. If that's what it's getting at, like if the Prostheses List benefit doesn't cover the entire amount, then the response is that the bundles that we're defining are specifically the benefit levels are specifically based upon Prostheses List scheduled benefits. So we'll be defining the benefit levels for the bundles based upon what will be the March 2023 expected Prostheses List. So currently, the August or July, since July this year, there was a reduction in the scheduled benefits for these items, and that was in line with the implementation determined by the department. And then there will be a further reduction in scheduled benefits that is expected to occur in March next year. And we're taking the identified items in August, we're taking their expected scheduled benefit levels at a device level, at a billing code level, as at March next year. And we're defining the bundling benefit levels as per that March 2023 Prostheses List. So that is what's going to define the benefits associated, not other costs that are outside the scope of those benefits.
Thanks, Trent. We've got more of a comment that maybe the panel would like to discuss. Some might argue that the items are already bundled into the theatre banding payments or the DRG payments. Does the panel have any comments on that?
So if they are, then I mean, I think the only way to understand that is to understand the agreement between insurers and hospitals. And if hospitals are raising charges using billing codes and insurers are paying benefits by billing code in response to those charges raised, and then there are other theatre charges raised by the hospital and benefits paid by the insurer associated in response to those charges raised, then I would expect the benefits paid don't overlap. And so you're not getting double payment by the insurer. And so, but we would be, I mean, I guess all we can do is just define what the bundles would be in terms of the Prostheses List. And if there is overlap with other, with other funding arrangements between insurers and hospitals, then we just hope that we can provide sufficient detail in these bundles that you can work out that as parties you can work out what that overlap is, and then define the two so that they can sit together as in the funding agreements.
All right, thanks, Trent. We've just got a couple of other comments around that question as well.
I was just going to say. So I was just going to say, James, that I think both this question also in answer to the previous question that Trent provided, I think it touches on many of the actual questions that we're asking in the consultation paper, and so we'd really be keen to hear from stakeholders about these sorts of issues and making sure that we not only that the data is fit for purpose, but also that we're interpreting the data correctly, which is really key to our understanding.
All right, thank you, Keith. Thanks, Trent. So we've got another question that's popped up. So if the recommendation is a given price for a bundle, will the current scheduled benefits be used as listed in the PL or public price be used? Yeah,
so I mentioned a minute ago on the previous question that we'll be using the benefit levels expected, to be published in March, to be in effect as of March 2023. By the way, these expected scheduled benefit levels have been published by the department on their website. So it's in the public domain, this information around what the expected scheduled benefits levels will be for devices in March 2023. And they're the actual levels that we'll be using as opposed to alternative information such as the benchmark prices. So we'll be using the actual implementation, the considered implementation of these benchmark prices within the department's decisions around Prostheses List scheduled benefits.
All right, thanks, Trent. We've got a slightly not Prostheses List question. So Lucy's just asking if this session will be recorded and available with captions at a later time. I'm not sure if we do have an answer to that.
I'm pretty sure that we usually, just speaking from experience, Joe, we usually record these sessions, don't we?
Yeah. We do usually record them. I mean, this is a bit different, less education, Q&A and stakeholder engagement from that perspective. But yeah, we are recording it. So yes, let's presume that it will be available later.
I hope Lucy got that in the subtitles.
So we've had a bit of a hold on the questions. There's been a few comments, but I don't think they're directly relatable as now. I guess while we wait for other questions to come in, I might ask you, Trent, to provide some steps we undertake to prepare the HCP data for use in developing our advice.
Yep, sure. So our intention is to use the HCP data from the 2020-21 financial year for the purposes of defining the bundles and defining their benefit. Defining the bundles, and also using that in conjunction with these Prostheses List schedule benefits to define the benefit levels of those bundles. We're also intending to use preceding years of HCP data up to that point, so 17-18 financial year, 18-19 and 19-20, and we'll be using those 3 preceding years of data to understand the variation in utilisation rates within these bundles, and that's particularly relevant with regard to the impact of COVID. So also in terms of the actual preparation of data for this exercise, there are several steps. One of the main steps is to really what we refer to as map the billing codes forward to August 2022, because each year of HCP data has got a set of billing codes that are native to that were associated with activity in that year, and those billing codes may no longer be active, and they may have transferred to other billing codes. They may have been duplicated, or they may have been compressed is another one. So there are various, as you know, different types of changes to billing codes on the Prostheses List. And so we look to identify transitions of billing codes from historical versions of the Prostheses List in such a way that we can map them forward when they transfer from one billing code that then becomes inactive to another one that becomes active. So we go through a process of mapping all of the billing codes forward to August 2022 version of the Prostheses List. We also similarly, but different, map the ICD classification and the ACHI codes forward to ICD 10AM and ACHI 11th edition. And we also group the data to DRG version 10 as part of the process. Then the main step, so that's just a bit of data prep, mapping the ICD code, mapping the codes forward to a consistent time period or frame of reference. We then look to do some data exclusions. The main data exclusion that impacts on a reduction in the records that we use is really excluding records or episodes of care that have that are grouped to an error DRG, and that really is code for episodes of care that have unknown principal diagnosis. Like, that is the main reason why the episode's grouped to an error DRG. So and predominantly these types of episodes where there is no clinical information, no ICD or ACHI information captured within and recorded within the HCP data, is associated to privately insured episodes of care in public hospitals. And that was sort of reference earlier on with regard to the quality of the HCP data in the public from the public sector. And so we do that exclusion, and that's going to obviously reduce the representation of the HCP data in the context of public hospital services. But aside from that missing diagnosis information, it's very small the amount of exclusions you make for that purpose, for grouping to an error DRG. And then there is the other major exclusion is we then have got these billing codes all mapped to the August 2022 Prostheses List, but then there are these residual records, billing device records, that do not map to the August 2022 prostheses list because they've become inactive and they haven't transferred to a different billing code, an equivalent billing code. And so you get this proportion of device utilization and associated benefits paid for a given year of HCP data, where we can't use that in the determination of the bundles because those items, well, they're just, there's no identifiable billing codes sort of to define, to use in these definitions of these bundles. And so there's that bulk exclusion, and we'll quantify all of this in the provision of our advice, all of these amounts. But the point about this particular exclusion is that it's not too substantial in the 2021 year. It's okay, and I think it's an acceptable with regard to the representation of the remaining amount after the exclusion. But the further back you go, so if you go back to 1920 and 18, 19 and 17, 18 financial years, the more and more, and it grows quite substantially, the amount of unmapped billing code device utilization data. And so that's
We've actually just got a question in about representable data that kind of leads on from your last comment there. So with the cancellation of a great deal of elective surgeries in 2021, how representative will the data from that year be, or the data sets that we're going to be using?
Yeah.
Yeah. Sure. So I think it's a good question, and of course that is one of the topics of the consultation paper, is to get an understanding of how COVID has impacted the sector. But what I will say is I think, you know, one of the issues that we're really trying to drill down into is conditional on a certain episode, or conditional of the use of a certain, or utilization of a specific episode. How could COVID have, or how could COVID have impacted the utilization of these general use items? I think overall, we're aware of the impact that it's had on the sector and on particularly on elective surgeries. But I think drilling down a bit further into that, so that's important to understand. But then drilling a bit further into that is, has there been any changes in the type of utilization, given that you are performing a certain type of surgery?
Great. Thanks, Keys. We've just got a quick question about the submission date. So will IHACPA offer any extensions on submissions?
I'll answer that one. We don't have a lot of capacity to offer extensions, as you would have seen from the timeframes that Trent outlined. We are due to provide this advice in December, which already the sector tells us is not enough time for them to prepare. I would encourage you to just get in touch with us through the submissions email to discuss. There may be capacity for a few days, but there is not significant time to, you know, for that extension. So yeah, just email us through the submissions email, and we can discuss with you what might be possible.
Great. Thanks, Jo. We've got a question about the DRGs and what we're using. So given private sector contracts are often written in old DRG versions, which version or versions will you be able to publish and maintain if you go down a DRG-based route?
This one could also be me, because it's my, pet topic of one of the reasons we're keen to continue to support the private sector in moving to more recent DRG versions, for a lot of reasons, not just for them to get value out of the more recent DRG versions, but also because it does create some challenges when old DRG versions are being used. So it is something we expect, I guess, that we would get feedback from in the consultation, and we would appreciate that in terms of version numbers still in use and the like. But we have put forward from July this year that versions prior to version 7 would not be supported by IHACPA. So anything other than that, is something that we would need to investigate. So again, I know this is a theme of all of our responses. Please let us know your views on that, about previous DRG versions. But we are conscious, we are trying to encourage the sector, and we can't, necessarily, it may not be feasible to go back to very early versions in sort of, providing our advice. So please let us know, and that's something we'll assess in terms of what is feasible when we start looking at the data in more detail.
All right, thanks, Jo. So another question for the panel. So what will you do if there's a difference in the amount that's claimed and the amount paid?
So there's an extent to which that may occur, and so you can that's we're able to see that within the HCP data because it has claim information as well as the benefits paid. However, like even separate to the actual charges and benefits that are recorded in the HCP data, what we're looking at is separate to those two parts of information entirely. It is just the device utilization, and we're attaching onto that device utilization the prostheses list schedule from March 2023. So it's just is removed from the actual data and how it records benefits paid and charges raised and differences between them. So we're not looking at any such differences. We're not looking at charges raised. We're not even looking at benefits paid as recorded in the HCP data, except the extent to which we're looking at the representation of the HCP data against APRA statistics. That's the only way we will use the benefits paid that are recorded in the HCP data.
Thanks, Trent. So we've got another question that's popped through from Caitlin. So will IHACPA include in their advice any commentary on the implausibility of widespread contracting between PHIs and hospitals in the few months between the conclusion of the advice and 1 July when the items dropped off the PL?
I think that we don't have like the actual. I feel like that's again a scope thing. Like we're going to provide advice, and hopefully we provide sufficient detail in like technical specifications and so forth of the advice that the advice is flexible enough to adapt to whatever the actual circumstances are around the development, the establishment of alternative contract arrangements. So I just don't think we have an ability to have an opinion on it. All we can do is really have regard to the fact that these sort of negotiations need to occur and try and facilitate them is effectively the outcome. And whatever information we can do, we can receive from hospitals and insurers that say for example, this is the sort of information that we require to facilitate our negotiations or whatever it might be. That sort of feedback to this consultation, I think, would be really important and valuable, so that we can ensure that the advice we provide is fit for purpose and can actually be used and has value.
All right, thanks, Trent. We've got another question from Patrick around the data as well. So does the data show that there are very different usage patterns for particular types of episodes of care based on the type or location of the hospital? And are there any examples in the data yet?
Yeah, there's substantial variation. I think this is what my issue is, which is like mine not mine, ours to resolve, right? Is that these are general use items, and they're called that for a reason. They are used across a wide range of services, and they're used in a wide range of ways, and so the utilization of them varies significantly. And there's only so much you can do to characterize the bundles and so forth in order to get tight sort of estimates around utilization rates and really cater for the variation in use. So we've certainly been looking at the data and doing the exploratory work to form these bundles in the best way possible. But there will be an extent to which obviously we just cannot replicate the device level payment system that the Prostheses List currently supports.
And I think that's the challenge for us in the next few months is to try and see where that variation is and what arrangements can be placed that aim to minimise that variation. And I'm just looking ahead, James, at some other questions. So I think that's certainly that variation is underpinning our work to deliver advice.
All right, thanks. We might have time for one or two more questions. So has there been consideration of how this change might impact the National Health Reform Act, particularly the revenue neutrality?
So I might take that. So yes, as the question implies, there is the National Health Reform payments to public hospital activity. Now within that, there are adjustments for private patient neutrality to essentially make the financial incentives as much as possible neutral for public hospitals. And so I think it's a very good question in that once we kind of get more of a sense of how this is going to play out, that we do look at how this could work into that particular adjustment for private patient neutrality.
Thanks, Keys. We've got time for our last question. So, will your advice on bundles include information on the variation in utilization rates?
I mean, I think that's the case. I think we have to provide some understanding of the variation in utilization rates. If it's just a single utilization rate and a single benefit for each bundle, I think that's a minimal set of information, and so it's going to be of limited value in the process of establishing alternative arrangements. So, and again, it's sort of what we're interested in feedback on, like what are the specifications of our advice? What are the technical specifications that we need to put in our advice to make it of value to the sector? And I think it would be more than just a single utilization rate and a single price.
All right, thanks, Trent. So that's all the time we have for today. So thank you to everyone who's attended, all our panelists, and all the questions that we've asked today. So with that, I'll take it back to you, Joanne.
Thanks, James. So that's all left to wrap up. I would just say thanks for the comment on Trent's background. We do agree he has the most photogenic background of anyone's home office at IHACPA. It is definitely very geometric. But yes, thanks to the panelists. Thanks again also for your participation and your questions. We hope it has provided you some insight, answered some of your questions, and helps you formulate your responses to the consultation paper. We look forward to your responses by the 12th of October, hopefully, and details of how to make those submissions are in the consultation paper and on the submissions page on our website. And I think that is it. Yes, I hope you enjoy the rest of your day, and thanks again for your participation.